today I thought it would be good to talk about where we are in terms of our national strategy or lack thereof, moving into the summer and getting ready for fall. This is something that a number of my colleagues and I have been discussing over the last couple of weeks. And the reality is, maybe as a default of really not making any additional decisions or taking actions, we've adopted the national strategy of just let her rip, right? That's kind of how we're approaching the summer and fall. We've got a number of people within the population vaccinated. We're getting some people boosted, but we're not making concerted efforts to increase those numbers with any large efforts. We're not doing any non-pharmaceutical interventions to mitigate community transmission. We're paying lip service to putting in additional provisions for protecting children in schools for the fall, but nobody's really making investments in changing HVAC systems or upgrading ventilation for the majority of public schools across the country. We're just going to let things ride as they are and let nature take its course at this point, because we've decided that it's not worth the effort and pain of these interventions and non-pharmaceutical interventions to reduce transmission. But in that, I think there are a number of assumptions that many folks are making, including policymakers. And I think it's worth taking a closer look at these assumptions of what the let her rip strategy really needs to be successful, or to at least avoid a catastrophic result in the fall. The first is the assumption that the vaccine that we have in the community now, and the fact that much of it is remote by at least 6 months and will be more by the fall, that level of vaccination and that remote vaccine provides good enough protection for folks in the high risk category. I think the second assumption that's in there is that these newer variants are milder, that Omicron and subsequent variants have produced milder disease compared to previous variants and versions of the virus, and the risk of hospitalization and mortality in low risk groups, so particularly people under the age of 65, is relatively low, even where vaccination is less common in these groups. I think the third assumption is that children are relatively protected from infection, and certainly from harm from infection. And then the fourth assumption is all of these new cases that continue to accumulate essentially just build the pool of natural immunity, and that the more people who get prior infection, it's just like getting vaccine, right? It's very minimal risk at this point, but provides good protection from harm in the future, and that repeat infections are inherently milder. And I think it's worth, again, looking at all of these assumptions with data that we have, especially recent data that's come out. So I think the first study to talk about is duration of protection, studies that are looking at duration of protection, especially for recent variants in recent periods of time. So this is a study that just was published out of Qatar a couple of weeks ago, and no surprise, again, this has been reproduced in multiple studies across a variety of different locations, but showing that vaccine effectiveness, especially 2 doses of vaccine over time, wanes dramatically. And as you can see, more than 7 months out, this study, at least in theory, shows negative vaccine effectiveness. I think we've talked about some of the biases that are built into these types of studies that make vaccine effectiveness look worse than it actually is, because of test-seeking behavior and selection bias. But I think it's safe to say that vaccine effectiveness for infection at 2 doses in recent times outside of 6 months is very, very low. And we see even for boosters, vaccine effectiveness wanes over time, as we see even a month after the 3rd dose, we're already seeing a decrement in effectiveness against BA1 and 2, and that's for both the Pfizer and the Moderna vaccine. So again, there we are, 7 months out, we have very low vaccine effectiveness against infection. The study also showed that the trends for boosters seem to be going down towards that minimal effectiveness as well. So even though you get a good boosting effect with boosters and you get a significant jump in protection, there's still a downward trend that if you extend that line from what we see in those data points, by about 28 weeks or 6 or 7 months, you're really getting down to probably very limited effectiveness against infection. Now, still maintains relatively good effectiveness against severe disease or fatal disease, as you can see on this bottom panels. But other studies show that those numbers start to wane as well. And we can see evidence of that in some of the data that's come out of Israel over the last couple of months. This study was published in April, but showed that people who had only had a third dose of the vaccine compared with the fourth dose had a dramatically increased rate of severe illness. You can see by 6 weeks, it was a fourfold difference compared to week 1 and 2, where you really had a very small difference. So this shows that even a third dose booster eventually starts to lose its effectiveness in the highest risk groups, even after a month or two. And again, if you trend that out over 6 months, now we're starting to really see some dramatic differences in terms of protection. This bears out in some of the neutralizing antibody studies that have been done as well, also suggesting that the newer variants continue to drift farther and farther away antigenically and make neutralizing antibody binding more and more problematic for people with prior infection or people who've been vaccinated. And you can see that if you got a booster dose, which is that first panel, that series of dots on the right after booster, that shows you that the booster gives you a dramatic increase in neutralizing antibody titers against multiple variants, but your neutralizing antibodies are much, much higher against the wild type strain WA or BA1 or BA2, much more so than they are against the more recent variants of BA2.12.1 or BA4 and BA5. And you can see there between BA1, which was the initial Omicron, and BA4.5, we're seeing greater than threefold reduction in neutralizing antibody titers from vaccine boosting effect. And so that is going to continue, I think, as variants continue to drift farther and farther away. We're going to see less and less good protection from a third dose booster, and that's probably going to require additional boosting in people being much closer in time to their last dose. So there's the data for BA4 and 5. So I think we can take that first assumption off the table, that remote vaccination is not going to be good enough. We need people to be up to date on their vaccines, and that means for high-risk people now having 4 doses of vaccine, not 2 doses. And we're probably going to need additional doses in the future. Now let's look at these other assumptions, that Omicron and newer variants are milder, and that people in the lower risk groups are going to have better experiences. And again, I think the data do not hold up to that assumption. If you look at the Omicron wave here in January of 2022, for demographics under the age of 65, you can see here even down and more pronounced in the younger age groups of 18 to 29 and 30 to 39, they had the highest rates of hospitalization in the Omicron wave compared to any other wave of the pandemic. And so far from being milder waves of infection, these more recent variants have produced more severe disease and more hospitalizations in younger people who, again, are less likely to be vaccinated than others. We can see here, even with the most recent wave of BA2.12 and now BA4 and 5 are on the scene in the US, we've seen a significant rise in hospitalizations here over the last several weeks across all of these age groups. So there we are, 18 to 29. By far the most hospitalizations they've seen in the pandemic were in the Omicron wave. And that means that these newer variants that we've seen over the last 6 to 8 months are not milder, they're actually more severe, and that holds up against all of these age groups. So we can take that assumption off the table. That's clearly incorrect as well. Now, what about the assumption that children are protected from harm and from infection? I think, again, the data from Omicron clearly shows that for children, they've had the most dramatic increase in hospitalizations in the recent Omicron wave as compared to others. And we can see that their rate of hospitalization, even from this small-ish wave of BA2.12 and now BA4.5, is almost as high as any other hospitalizations they've seen in any subsequent wave. And over the course of the last school year, so from the beginning of August of 2021, you can see that in the middle of August, we had 402 pediatric deaths by the American Academy of Pediatrics counting. And that's about 94% of the US population that gets captured in this. And by the end of the school year, the beginning of June, we had over 1,000. Right, so well over 600 deaths, or 60% or more of the deaths we've experienced in kids over the course of the pandemic has occurred in this last school year. And again, remember, we've had 2.5 school years that have occurred during the pandemic, but the last one is responsible for the vast majority of deaths we've seen. So severe outcomes in children are becoming more common, not less common. And I think that bears out when you look at the peak incidence. Again, in the Omicron wave, the peak incidence of hospitalizations that we saw in all of the young age groups, age 0 to 4, age 5 to 11, age 12 to 15, were 2 to 3 times higher than they were in the previous peak in the prior winter in January of 2021. So dramatically increased hospitalization rates that we've seen with more recent variants compared to previous. If you look at hospitalization data from Florida, you can see that even in this most recent wave of BA.4/5, we're now approaching hospitalization rates that we saw in the previous peak waves and are starting to climb up towards what we saw at the peak of Omicron. So even recently, we're not seeing a dramatic reduction in pediatric hospitalizations in many areas with low vaccination rates in kids like Florida. We're seeing a dramatic increase, and that's bringing us into the fall in a much worse position than we were in the fall of 2021. So I think you can take that assumption off the table. And now that last assumption, that essentially once you're infected once, you have some immunity and that protects you from severe outcomes later. I think this recent study that came out in preprint from the VA system in the US is probably going to blow a big hole in that as well. Now, this, again, has not been peer reviewed. It is available in preprint, but this is from the group that's done those amazing analyses of VA health system data looking at post-COVID sequelae of cardiovascular complications, neurological complications, et cetera. We've talked about a number of these studies in our morning sessions. So this study looked at veterans who had an initial dose of COVID and then looked at people who got reinfected. So about 260,000 who had an initial experience of COVID-19, and then about 39,000 who had reinfection, and looked at complications of reinfection compared to complications of primary infection. They also used over 5 million veterans who had no diagnosis of COVID-19 as a baseline comparison group as well. Now, there are 1 or 2 problems in this study in terms of making it a little bit difficult to generalize. First of all, it is the VA, so participants are a bit older and much more male than the general population. There's certainly a baseline preponderance of certain underlying conditions, current smoking, for instance, which is well above what we see in the general population. And a significant proportion were in long-term care. And you can see that a more significant proportion were in long-term care, which makes the comparison a little bit more difficult to attribute all to what they're trying to measure. And again, higher rate of dementia in the reinfection folks. And again, that probably correlates with more of them in long-term care. However, I think there's some important trends that they found. One other thing to point out is a minority of these folks required hospitalization. So important to point out that these were not folks who were the sickest of the sick. Always, many of them were outpatient cases of COVID-19. Sorry, going backwards. And a minority of them had vaccinations. But what they found was for reinfections, right? So this is comparing your experience with your second or third infection with your experience with the first infection. You had an increased risk of death with reinfections compared to initial infections. You had an increased risk of hospitalization with reinfections compared to initial infections. you had almost twice the risk of developing post-COVID complications from a reinfection compared to initial infections. And that was true across the board for all of the different syndromes and organ systems they looked at. And so far from being milder in these cases, reinfections actually carried more risk of hospitalization and complications compared to initial infection. I added that red dotted line because that's a twofold risk increase. And you can see that there are a number of complications, including hospitalization, which is more than 3 times the risk, which dramatically increased after subsequent infections compared to the first infections. Now, again, important to point out that they did exclude people with primary infection who died within the first 30 days. And then the analyses they did were 30 days after a diagnosis. And so there's probably some survival bias that's being thrown in there. So maybe the mortality and hospitalization ratios might be a little skewed towards more dramatic effect, but I don't think enough to reverse that trend, right? To indicate that reinfection was milder. I think still quite clearly reinfection was more severe, and the post-term complications I don't think would be affected by that. And so all of those post-COVID complications still appear to be dramatically increased in likelihood for reinfection compared to initial infection. And this was also true in folks who had vaccinations versus non-vaccinations. Now, this isn't showing that 2 vaccines don't protect you compared to no vaccines, but what it is showing you is that in people who were vaccinated, their second and third infections were still worse than their primary infections. And so getting infected more than once, even if you're vaccinated, is not a good thing. It doesn't make you more protected. It just exposes you to more risk of infection. And that's what we see there. That all-cause mortality more than twice of the initial infection in all categories there. And then finally, this is looking at sequelae of all-cause mortality, hospitalization, and post-COVID sequelae. And it shows that you not only see a dramatic increase at 30 days, right? So 1 month after your bout of infection, but that increased risk continues 6 months out and more. You're still seeing higher rates of complications and higher rates of hospitalizations, even that far out after your diagnosis. And so that's after your initial diagnosis or after your diagnosis of reinfection. And that's true across the board for all of the different organ systems that they looked at. And then finally, having 3 infections is worse than having 2 infections, which is much worse than having 1 infection. So again, that dose response curve that we see here indicates that subsequent infections are not a good thing, right? They're not going to be necessarily milder, at least in this VA population. And I think we need to think about, does that translate into younger patients? And does it translate into kids, right? Because we've, I think, clearly gone under the assumption that initial infections in kids are probably not a big problem. And then subsequent infections just have to be even less of a problem because we are infecting kids multiple times now. I think it's true that a large proportion of school-age children in the US have been infected more than once now over the course of the pandemic. And they will be infected again when we send them back to school in the fall. But we're operating under that assumption that reinfections really aren't a big deal. And I think these data show that, at least in this population, they are a big deal. They carry increased risk compared to initial infections. And so that assumption is really shot down as well. So all of these assumptions that really have to be true and valid for the letter rip strategy not to result in a horrendous experience in the fall, all are really proven to be false. And I think lead us to anticipate what I think is going to be, unfortunately, a very difficult experience this fall. So that's all I have. Thanks, Shelley.